Before we dive into today's episode, I want to take a moment to dedicate it to some incredibly inspiring women, our group coaching members and patients who are more than 10 years post-menopause and even into their 70s, who made the bold decision to start HRT with our guidance. You know who you are, and I see you. You chose not to settle. You chose to fight for your energy, your clarity, your bones, your mood, your life. And even though it's not always a fast road, you're feeling better. Slowly but surely, you're reclaiming your health, and it's been an honor to walk that journey with you. This episode is also dedicated to the moms of our members. Yes, you baby boomers. A few of your daughters asked me directly, can you please do an episode for my mom? She needs to hear this. So this one's for all of you because it's never too late to take your health back. The baby boomer generation of women got royally screwed. Dr. Peta Attia calls the Women's Health Initiative the biggest medical screw up in history. And I couldn't agree more. Millions of women were scared of hormone replacement therapy overnight. Not because the science said it was dangerous, but because the data was twisted. The headlines were sensationalized and the truth got buried. As Dr. Avram Blooming, world-renowned breast oncologist, put it, let's call it what it is, scientific malpractice. The WHI study distorted their findings, and for the past 23 years, women have paid the price with their bones, their brains, their sleep, their hearts, their relationships, and their quality of life. And here's the thing, many of these women are still paying for it. Now in their 60s, 70s, even 80s, they're asking, can I still take HRT? Is it too late to benefit from it? Is it even safe anymore? Today I'm breaking down exactly what the science says about starting HRT more than a decade after menopause. You're going to hear what we're seeing in real life clinical practice and what you need to know if you're considering HRT in your later years. The idea that menopause symptoms magically disappear after a year or two, that is a big pile of you know what. About 1/3 of women are still dealing with moderate to severe symptoms a full 10 years and more after menopause. A decade later, and the hot flashes, night sweats, insomnia, mood swings, and fatigue haven't let up, which is so awful. Women have it tough. It's a wonderment that women have been treated as the less superior when compared to men. Over 35 years of bleeding monthly, pushing watermelon-sized humans out of our vaginas, enduring 100+ symptoms of menopause. Yes, that's a real number. And we're still getting up every day, working, parenting, caretaking, holding it all together. So, well, sometimes, maybe not always, holding it together. So if you're still having symptoms 10+ years post-menopause, you're not imagining it. And you're certainly not alone. That's the women who are reporting their symptoms. My guess is it's much higher than that, as women are notorious for sucking it up and dealing with pain or uncomfortable symptoms. Even more eye-opening, 10 to 15% of women continue to experience vasomotor symptoms, the fancy term for hot flashes and night sweats, for up to 15 years post-menopause. And while hot flashes get all the attention, let's not forget sleep gets disrupted, energy tanks, bones go, mood dips, relationships suffer, quality of life nosedives. The truth is, millions of women were told, just grin and bear it. And now, decades later, they're still suffering. Past 15 years post-menopause. And they're asking the question that medicine is finally starting to face. Can I still do something about this? Now, of course, the answer is nuanced and it is hopeful. And most doctors aren't telling you what your options are. Most of the research on HRT, and this is where your doctor is getting it from, especially the scary sounding stuff, was done on one type of hormone therapy, oral estrogen, specifically Premarin, and synthetic progestins, not bioidentical, not transdermal, and definitely not the kind of hormone therapy we're using in modern functional and integrative medicine. That's a massive problem. Premarin is a conjugated equine estrogen, aka estrogen from horse urine, and the synthetic progestins used in those studies, like medroxyprogesterone acetate, behave very differently in the body than natural progesterone. The Women's Health Initiative, the study that scared a generation of women off hormones, was built around these outdated forms. And what did it show? The oral estrogen increases your risk of heart attack and stroke, especially if started more than 10 years post-menopause. That is where this no bueno after 10 years comes from. Not only is there research primarily on Premarin, it is also on synthetic progestins, which come with increased risks for breast cancer and cardiovascular disease. So yes, the data does show that the risks outweigh the benefits if you start oral hormone therapy, including synthetic hormones, late. And here's the catch. Those risks, they do not apply to transdermal estrogen and bioidentical progesterone. In fact, transdermal estradiol does not increase clot risk like oral estrogen does. Bioidentical progesterone has a neutral or even protective cardiovascular profile in many studies. And the stroke heart attack risks that everyone quotes, they're linked entirely to oral estrogen metabolism in the liver, not topical or transdermal delivery. But what about transdermal estrogen? What happens when we use estradiol in patch, gel, or cream paired with bioidentical progesterone? Well, unfortunately, the research, while more limited, it is incredibly reassuring. Studies like ELITE and KEEPS have shown that transdermal estradiol does not increase the risk of heart attack or stroke, even in women with cardiovascular risk factors. And in younger postmenopausal women, it can even slow the progression of arterial plaque buildup. In fact, the North American Menopause Society now states clearly transdermal estrogen is preferred in women with elevated cardiovascular risk because it bypasses liver metabolism and doesn't increase clotting factors. That's huge because when you skip the liver, which is what transdermal does, you avoid the spike in clotting proteins that's responsible for the increased stroke and heart attack risk seen with oral estrogen. If you already have heart disease or advanced atherosclerosis, HRT won't undo the damage. But starting transdermal estradiol with the right support doesn't appear to make it worse. And in healthy older women, it may offer symptom relief without raising cardiovascular risk. What it can do is make women feel better, boost energy, help with muscle growth, which can propel a woman to start exercising, which, as you all know, helps with cardiovascular disease, help with cravings, and improve insulin sensitivity. So when we're talking about HRT after age 60 or more than 10 years post-menopause, It's not a hard no. It's a qualified yes, with the right formulation, delivery, and monitoring. Because transdermal and bioidentical are a completely different story, so when you're reading headlines or your doctor tells you it's too risky to start HRT this late, you need to ask, what kind of hormones are we talking about? And how are they being delivered? The North American Menopause Society now recognizes the safety of transdermal estrogen, especially estradiol and micronized progesterone, particularly in women with cardiovascular risk. Here's our quote: transdermal estrogen therapy is not associated with increased risk of venous thrombolism, stroke, or myocardial infarction, and is preferred in women with elevated baseline cardiovascular risk. The KEEPS trial compared oral conjugated estrogen versus transdermal estradiol and cyclic progesterone in recently menopausal women. They found no increase in blood pressure or cardiovascular markers with transdermal estradiol. Bioidentical progesterone showed better tolerability and fewer mood effects than synthetic progestins. The ELITE trial. What it showed, this landmark trial compared women who started HRT less than 6 years post-menopause to those who started more than 10 years after. In the early group, estradiol slowed the progression of atherosclerosis. In the late group, estradiol did not worsen cardiovascular health, but also didn't reverse damage already done. The takeaway, starting at transdermal estradiol early is more effective for heart protection, but starting later does not increase risk when using the right delivery and formulation. Now let's talk bones, because the estrogen loss that comes with menopause doesn't just affect sleep and sanity. Without HRT, 27% of women over 60 are diagnosed with osteoporosis. 50% of postmenopausal women will experience an osteoporotic fracture in their lifetime. And up to 20% of your bone mass can vanish during and after the menopausal transition. This is massive. Bone loss isn't just some abstract number. It's broken wrists, fractured hips, lost independence, and a serious higher increase of early death. And yet, this has become normalized. Globally, around 30% of postmenopausal women have osteoporosis. In the US, it's even higher for Caucasian women. 30% with osteoporosis and a whopping 54% with osteopenia. That's over half of women walking around with bone density low enough to be at risk. Many of them never told they could do something about it. And when I hear some doctors say, oh, only Western women experience menopause like we do, I call BS on that. This isn't a cultural phenomenon. It's a reality for women around the world. Estrogen drops and women pay the price. Period. Whether you're in Vancouver, New York, or Istanbul, your bones, brain, and body feel the loss because you are come from a different culture. You have different color skin. It doesn't remove you from the detrimental effects of hormonal loss. Your body doesn't go, oh, you were raised in China, so you don't have to have osteoporosis from the loss of your estrogen. It does not work like that. So when you hear doctors say North American women are the only culture that is experiencing the effects of hormonal loss in menopause, that is a lie. When it comes to bone health, the timing of hormone therapy really matters. The strongest benefits, like everything else, are seen when HRT is started within the first 3 to 10 years after menopause. And that's because estrogen loss happens fast and furious in those early years, and that's when your bones are most vulnerable. Starting HRT during that window helps preserve bone mineral density, slow the acceleration of bone loss, reduce fracture risk. But when you start more than 10 years out, the story changes. By that point, a lot of bone mass has already been lost, and unfortunately, HRT can't magically rebuild what's already gone. However, HRT may still help maintain bone density, even though it won't rebuild what's lost. Similar with the heart stuff. Transdermal estradiol and oral estrogen, even though I don't agree with oral estrogen, this is what the research shows. Transdermal estradiol and oral estrogen can still have a bone-sparing effect, even when started later in life, including after age 70. That means it may slow down further bone loss, but it likely won't reverse osteoporosis or rebuild bone that's already been lost. One study in the Journal of Clinical Endocrinology and Metabolism in 2001 found that older women, mean age was 74, who started HRT had significantly reduced rates of bone loss at the hip and spine compared to those who didn't take it. In the WHI trial, even women aged 70 to 79 who started estrogen had some reduction in fracture risk, especially hip fractures, which, by the way, can kill you. However, the absolute benefit was smaller than for women who started earlier because those women had already lost more bone mass by the time HRT began. The reduction in vertebral fractures was more significant than for non-vertebral fractures, possibly due to bone density differences. Current guidelines say HRT can be used in older women for bone, but with caution. The North American Menopause Society and the Endocrine Society both state that HRT is effective at preventing bone loss and reducing fractures. They also acknowledge that it can be started in older women, but the risk-benefit profile needs to be evaluated carefully, especially cardiovascular and clot risk, because it is based on oral estrogen. Low-dose transdermal estradiol and micronized progesterone is preferred in older women due to the better safety profile. If you started HRT early and then stopped, I get this question a lot too. Some benefits hang around, but once you're off it, your bones pretty much go back to losing mass at the same rate as everyone else not on hormones. Bottom line, if you're hoping late start HRT will rebuild your bones or dramatically reduce fracture risk, it probably won't. While late start HRT can offer some bone health benefits, these are substantially less than when started closer to menopause onset. But, and this is important, it doesn't mean HRT is pointless if you're past that 10-year mark. Now, while hot flashes and knife sweats may grab the spotlight, there's another postmenopausal issue that's just as impactful, if not more so, and that's Genitourinary syndrome of menopause, or GSM. If you're thinking, what the heck is GSM? You're not alone. GSM is the updated term for what used to be called vaginal atrophy, but it's so much more than just vaginal dryness. It includes burning, itching, irritation, painful sex, urinary urgency, frequency, and infections, and loss of elasticity and thinning of the vaginal walls. And this it doesn't go away with time. Unlike hot flashes, which usually ease up after a few years, GSM gets worse the longer you're postmenopausal. Symptoms show up in about 65% of women just 1 year after menopause. By year 6, that number climbs to 84%. And by year 10, it's still over 50% and often even higher. This isn't some short-term nuisance. This is a chronic condition caused by the ongoing lack of estrogen affecting the vulva, the vagina, and the entire urinary tract. And most importantly, it doesn't resolve on its own. Women suffer in silence for years, sometimes decades, because no one told them there was a name for it, let alone a treatment. But there are treatments, and guess what the gold standard is? Local vaginal estrogen. Safe, effective, and incredibly well tolerated, even in women well beyond that 10-year mark. In fact, low dose vaginal estrogen doesn't significantly raise systemic estrogen levels and is considered safe even in women with a history of breast cancer. So if you're 60, 70, or even 80 and dealing with burning, leaking, dryness, or painful sex, you are not too late and you are not out of options. One of the lesser known but totally real effects of long-term estrogen loss is the shrinking or even vanishing of the labia minora, aka the inner lips. This isn't just cosmetic. These delicate folds of skin play a crucial role in protecting the vaginal opening, maintaining moisture, and supporting sensation and sexual pleasure. Post-menopause without estrogen, the tissue can become paper thin, less elastic, and start to fuse or retract, sometimes to the point where the labia seem to disappear. And no, you're not crazy. This is a documented part of GSM. Your labia isn't just there for decoration, ladies. They help shield the vaginal entrance from bacteria, dryness, and irritation. It helps to maintain a healthy vulvar pH and microbiome, preserve clitoral and vaginal sensitivity, support sexual confidence and comfort. So, if you've noticed changes down there, shrinking, dryness, irritation, or pain during sex, you're not alone. And this, by the way, can happen through perimenopause as well. I think it's the percentage of women that get this in perimenopause is about 50%. So about half of us are going to experience issues with our vagina and vulva and everything down there, the urinary tract, and it needs to be addressed. Like, women should never, ever have to go through this. I have heard horror stories. I've experienced this myself, and it is not fun, it's not pleasant, and it hurts. So can you regrow your labia minora after menopause or GSM? Not fully, but you can absolutely improve the structure, thickness, elasticity, and overall appearance of the labia minora and the entire vulva with the right interventions. So while we're not talking about magically sprouting a new labia like a lizard growing a tail, there is hope. Estrogen doesn't just help you feel better, it can literally help your vulva come back to life. This is huge. Topical vaginal estrogen, whether it's estradiol or estriol, regular use can rebuild tissue thickness, restore elasticity, and increase blood flow. While it may not fully regrow the labia minora, it often plumps the area back up and improves the integrity and sensitivity of the tissue. Many women see significant improvements within 8 to 12 weeks of consistent use. Like, how good that must feel to get your vagina back in working order. Oh, the things we have to put up with as women. DHEA. Suppositories. DHEA is converted locally into estrogen and androgens. This can help improve tissue integrity, moisture, libido, and possibly even some structural changes over time. Studies show increases in vaginal cell maturity and elasticity with regular use. Topical testosterone, off-label but super powerful. Testosterone helps thicken and strengthen the vulvar tissues, especially in androgen deficient women. It's particularly helpful for women with labial fusion or severe GSM that's caused tissue loss. Oh, that sounds terrible. And I sympathize for any of you listening that are experiencing this, that it must be absolutely awful. Awful. And I will say, using all of these topically down below can also help to enhance orgasm quality or even get your orgasm back. A lot of women find that it becomes very hard to reach orgasm, if at all, from GSM. So this can help with that as well. And this is a good time to tell you all that our new vaginal moisturizer, Velvet V, is going to be in our shop. Well, it's probably going to be in the shop by the time this podcast airs. Yes, this has been in the making for like 6 months. So I am so excited to offer this. It contains a good dose of estradiol, which is amazing for vaginal tissue, and DHEA, both safe for vaginal tissue. Both work absolute wonders on GSM. Not that I can make any claims. I'm just saying estradiol and DHEA are known to be really great, and you can see it in the research to help with GSM. And I'm going to give you all a coupon code to all of you women that are suffering with this. Coupon code VAGINA, of course. What else would it be? And you can get 15% off your first bottle of Velvet V. So can you grow it back? Well, not like it was when you were 25, but with the right hormone therapy, like the local estradiol or estradiol, or possibly DHEA or testosterone, and support therapies, there's other things you can do. There's red light therapy and things like this. You can absolutely restore tone, structure, and sensation to your labia and vaginal tissues, even in your 60s, 70s, or beyond, which is pretty exciting. All right. Well, most metabolic improvements are more pronounced when HRT is started early. Like everything else, you're like, yeah, Karen, I know this already. Obviously, I should have started it earlier. But I just want to point that out because that's, when I'm going through all the research, this is what's repeated over and over and over again is, when it is started earlier. When it is started earlier, you're going to get so much more. Anyways, when it comes to metabolic improvements, when HRT is started early, several studies show benefits, but they also show benefits in older women. Now, transdermal estradiol improves insulin sensitivity, glucose metabolism, and lipid profiles, even when initiated later in postmenopause. One study found estradiol reduced abdominal fat and improved insulin resistance in postmenopausal women, even in those who were more than 10 years out. In the KEEPS trial, women using transdermal estradiol gained less visceral fat compared to placebo. While this study focused on early menopause, follow-ups suggest continued estrogen therapy helps prevent further fat redistribution with age, especially the shift to central belly fat. Hey, we'll take that. Yeah, it's better than nothing. Even when started later, HRT can help blunt the trajectory of fat gain, which tends to continue, particularly visceral fat, which is most strongly linked to insulin resistance, diabetes, and heart disease. Here's a little bonus note. Estrogen also affects adiponectin and leptin, two key hormones in fat regulation. Estradiol increases adiponectin levels, which improves fat burning and glucose control. As well, we have estradiol receptors in the hunger centers of our brain. So a lot of women find that when they start using estrogen at no matter what age, it helps control their eating habits, the bad habits. Okay, so most studies, early or late HRT, show no dramatic change in actual body weight, but what does shift quite a bit is body composition. Less abdominal fat, slight increase in lean muscle mass, improved fat distribution. So while HRT probably won't cause dramatic weight loss, it may help prevent further weight gain and make weight loss easier when combined with the right diet and lifestyle changes, of course. All right. A review in the Lancet Diabetes and Endocrinology in 2021 confirmed that estrogen therapy, especially transdermal, continues to offer cardiometabolic protection, improves endothelial function, and lowers inflammation even in older women, though the greatest benefits occur when started earlier, of course. So if you're more than 10 years post-menopause and thinking HRT will magically melt the muffin top, not quite. But it can help reduce visceral fat accumulation, improve insulin resistance, support healthier cholesterol and blood sugar levels, shift fat distribution in a more favorable direction. It won't replace diet, strength training, or walking your butt off, but it sure as heck can make a lot of that work better. All right, let's talk about the brain, because when women ask, can HRT protect me from Alzheimer's if I start it late? The answer we hear most often is nope, too late, might even make things worse. But here's the thing, nobody tells you. The scary data, the stuff that says HRT increases your risk of dementia if you start after 65, it's not about all hormones. It's about the wrong ones. Again, most of the data comes from the Women's Health Initiative memory study, the WIMS trial. In that trial, women over 65 were given a combo of, can you guess? Oral conjugated equine estrogen, a horse urine derived estrogen, and medroxyprogesterone acetate, a synthetic progestin. The result? Women had double the risk of dementia compared to placebo. Scary. But this combo, oral Premarin and MPA, is not what we use in modern evidence-informed HRT. And this is so important. MPA, you guys, is not the same as natural bioidentical progesterone. In fact, multiple studies show MPA can actually block estrogen's benefits in the brain. Here's what MPA has been shown to do. Impair memory and synaptic plasticity, increase beta amyloid plaques, trigger inflammation in brain tissue, disrupt mitochondrial function in neurons. Meanwhile, bioidentical progesterone has been shown to support myelin repair, that's in the brain, calm inflammation, possibly even stimulate neurogenesis, new brain cells, baby. Researcher Roberta Brinton has published extensively on this, calling out how bioidentical progesterone behaves completely differently in the brain compared to synthetic progestins. Now let's make this even more disturbing. Because FYI, do you know how many women are put on progestins in menopause and perimenopause instead of bioidentical progesterone to help with their symptoms of perimenopause and menopause? That's just wrong. Medroxyprogesterone acetate isn't just an old school HRT. It's also the active ingredient in Depo-Provera, the birth control shot that millions of women have been injecting for decades. Yep, the same synthetic hormone that may increase dementia risk in older women has been widely given to teenagers and women in their 20s to shut down ovulation for months at a time. Make it make sense. So yes, when it comes to HRT and dementia, timing matters, but form matters too, a lot. If you're 65 plus and someone tells you all HRT increases dementia risk, ask, which HRT are we talking about? Because transdermal estradiol and bioidentical progesterone, so far the studies show it's likely neutral or possibly protective if started earlier. And even when started later, it hasn't been shown to cause harm the way oral Premarin and synthetic progestins have. So the takeaway here is this. It's not just about when you start HRT, it's also about what you start. Because not all estrogens are created equal, and some progesterones, they don't belong anywhere near your brain. What about reversal? Enter Dr. Bredesen and the multi-factor brain protocol. Now, I've had Dr. Bredesen on the show before. You can look him up. Just type in Karen Martell and Dr. Dale Bredesen. Now, before we close the book on brain health and HRT, I want to bring this up. He is an incredible Alzheimer's researcher. Like, he is leading the way. If you've never heard of him, he's a neurologist and researcher who developed what's known as the Bredesen protocol, a multi-pronged approach to preventing and in some documented cases, even reversing cognitive decline. Reversing. Nobody has been able to claim that yet. Now, this isn't just a pop a patch and fix your brain kind of deal. Bredesen's protocol is a systems-based approach that addresses the dozens of contributing factors to neurodegeneration. Things like insulin resistance, vitamin D and B12 deficiencies, sleep apnea, chronic inflammation, and you guessed it, hormone loss, including thyroid, estradiol, progesterone, cortisol, high cortisol typically. In his clinical work, Bredesen does include estradiol therapy, even for patients who are already showing signs of cognitive decline. Why? Because estradiol regulates gene transcription, supports mitochondrial function, and influences pathways tied to beta amyloid and tau, the two big troublemakers in Alzheimer's pathology. In one of his published case series, patients on his protocol, including those in later stages, showed measurable cognitive improvement. And hormone replacement, when appropriate, was part of that picture. The trial reported 84% moderate cognitive improvement after 9 months. Now, he's not saying estradiol alone will cure Alzheimer's. Let's not get carried away, but he is saying it's a crucial tool in the broader toolbox, especially if a woman is showing signs of hormonal depletion alongside cognitive decline. This is huge because it challenges the outdated idea that once the brain starts slipping, there's nothing we can do. Not true. Timing still matters, but with a multi-layered root cause approach, there may still be benefits even if you're past that ideal window. So if you're in your 60s or 70s and worried about brain fog, memory loss, or family history of Alzheimer's, please don't write yourself off. You deserve a provider who looks at the whole picture, and yes, that includes your hormones. Okay, so we've talked about the risks, the myths, the misinformation, the science, but what if you're still sitting here thinking, okay, Karen, I still want to try HRT. I'm 65, I'm 75, I feel like crap in many areas, and I'm not ready to feel this way for the rest of my life. Totally fair, and I'm so glad you are taking control. But before we just slap on a patch or start rubbing in some cream, we need to assess the terrain. Starting HRT more than 10 years post-menopause requires a more cautious approach, but it can absolutely be done safely with the right workup. We've covered testing, risk assessment, and all the groundwork you need before starting HRT post-menopause. So let's talk about how to actually start, because if you're more than 10 years post-menopause, the how matters just as much as the what. First and foremost, obviously, you want transdermal estradiol always. There's many clinics now, telemedicine clinics, private clinics, that do nothing but offer bioidentical oral estradiol. And even if it's bioidentical and not Premarin, you're still raising your risk of heart attack and stroke. So, always transdermal. That means patches, creams, gels, oils, not pills. Because then we won't be increasing our risk for blood clot, stroke, or heart attacks. Now, I'm not saying that you can't still get any of those things. You can. But using transdermal is not going to increase that risk. It skips the liver entirely, keeps hormone levels more stable, and is much safer for your cardiovascular system. It's not even a debate anymore. Clinical guidelines recommend transdermal for older women or anyone at risk. Second, you want to go low and slow, but not because your receptors shut off. Here's the deal. Most people, include some docs, don't talk about after 10 or 20 years without estrogen, your hormone receptors haven't gone dormant. They've adapted. Estrogen receptors, progesterone receptors, and androgen receptors, they all adjust their sensitivity based on your internal environment. Some become less sensitive in metabolic tissues like muscle or fat, which can impact things like weight, insulin sensitivity, or cholesterol. But in areas like the brain, mood centers, or even the reproductive system, receptors may become more sensitive, especially to fluctuations. So when you reintroduce hormones after a long drought, those receptors can respond in an unpredictable way. If you flood your system with a full dose out of the gate, you could very easily experience breast tenderness, cramping, spotting, anxiety, agitation, sleep disturbances, weird mood swings. It's not because hormones are bad. It's because your receptors are trying to recalibrate after years of hormone silence. They're not gone. They're just jumpy. That's why we start low. Give your body time to respond and slowly titrate up to your therapeutic dose. We're retraining the system, not flipping a switch. Think of it like reintroducing light to a room that's been pitch black for a decade. You don't want to blast a stadium spotlight. You want to turn on a dimmer and slowly titrate up. So when you're starting HRT, here's the golden rule. Transdermal, low and slow, safer, smarter, and way more sustainable. It's not just about easing symptoms, but rebuilding trust with your body and your receptors. They're still listening. They just need a little reintroduction. And here's what you want to get tested and checked before starting HRT. This is very important. Please see your doctor about the following. Number 1, cardiovascular risk assessment. This is the biggie because heart health is the main concern with late start HRT. Ask your provider to calculate your 10-year ASCVD risk score. If you're over 10%, that's high risk, and you'll want to proceed very carefully with the guidance of your doctor. If you're in the intermediate zone, transdermal estradiol is usually, of course, the safer option. You want to do baseline blood work. A good hormone strategy starts with a metabolic snapshot, a lipid panel, a glucose, fasting glucose, hemoglobin A1C, fasting insulin. You want a liver function test, especially if you're considering oral HRT, which I'm sure you're not. I hope you're not. You want a coagulation panel if there's a personal or family history of clotting disorders, and a CBC for general health baseline. 3, a bone mineral density scan, DEXA. This is critical in older postmenopausal women. Even if HRT won't fully rebuild bone, it can help slow further loss, and that matters. And so you can track it with a DEXA scan. Cancer screening. No one loves this, but it's a non-negotiable. Please go get your breast checked. I did a great podcast with Dr. Jen Simmons, and she talks about this new type of mammogram that you can get that is far less toxic than the usual mammograms. Go listen to that podcast, but you do want to have your breast checked. That could be a mammogram. After listening to Dr. Jen Simmons, I'm kind of on the fence about mammograms. I think that, they can be good, and they have definitely caught some breast cancer, but there's a lot of bad to them too, which I think women are not taught about. So go listen to that podcast. Tell me what you think, and get your breast tested. A pelvic ultrasound or an endometrial biopsy if you still have a uterus and you're going on estrogen. I think that that's very important. A pap smear, a pelvic exam, always good. And some additional assessments, blood pressure check, always full personal and family history, any breast cancer, heart disease, stroke, blood clots, or liver disease. If you're dealing with GSM, like dryness, burning pain during sex, this is where local vaginal estrogen or DHEA can come in and work magic safely with minimal systemic absorption. So those are the big tests to please have done before starting HRT. Cover all your bases, safety first. Final thoughts. Think of this as hormone rehab. You don't want a shock. You want a slow, beautiful awakening. With the right dose, the right delivery method, and the right guidance, it's never too late to take your health back. All right, ladies, thank you so much for tuning in. I wish you all of you baby boomers, the best of luck with this. And I know you can reclaim your health.